So our topic today is a really important one. It's on frailty. And I say it's important because frailty is a detrimental or a vulnerable state of health that increases the risk of many adverse outcomes, including mortality. And it's a particularly important one for us here at Atria because two of our focuses is on cardiovascular health and brain health. And I say it's important for those areas because frailty is an independent and a substantial risk factor for cardiovascular mortality, and that's even independent of cardiovascular risk factors. It's also now thought to be, even though it wasn't in the Lancet Commission, a modifiable risk factor for dementia, and in fact, a target for preventive neurological and for preventive brain health measures. So we're particularly excited about the topic today, and even more excited because of the speaker we have on this topic. So our speaker today is Dr. Kenneth Rockwood. I found out today Dr. Rockwood actually hails from the same area of the world that my family hails from, which is in Newfoundland. And for those of you who don't know, Newfoundland is a rock in the middle of the Atlantic. And to give you a sense of the kind of people in Newfoundland and the spirit of Newfoundlanders, Dr. Rockwood comes from a place called Heart's Content. That's the kind of people who live in Newfoundland. Dr. Rockwood is also from my alma mater. He's a professor of geriatrics and a professor of neurology at Dalhousie University in Halifax, Nova Scotia. He's also the Weldon Professor of Alzheimer's Research at Dalhousie University, and he's the inaugural director of the Frailty and Elder Care Network in Nova Scotia. He's published over 400 papers. He's published 9 books, including the 8th edition of a seminal textbook in geriatrics and gerontology. I like to look up our speaker's H indices and citations, and he's got an H index of 129 with almost 100,000 citations. So he's internationally renowned in this field, and he's also developed, importantly, a Clinical Frailty Index, which I hope that we will incorporate here at Atria. In fact, he's received many awards, as you can imagine, but the most recent of which I found online, he wouldn't put this in his bio because Newfoundlanders are too modest for that. But he received a very prestigious international award in New Zealand last year for his development of that Clinical Frailty Index. So Dr. Rockwood, we normally do these vanguards virtually, but Dr. Rockwood was kind enough to actually get on a plane, one of his first trips since the pandemic, and come down to New York to visit with us. And so we're delighted to have him, Dr. Rockwood. Thank you so much for being here.
Thank you for that generous introduction. As we say at home, not too bad for Newfoundlander. I'm glad for the opportunity to speak on this topic. And let's see, very good. And I've sort of provoked things a little bit by saying, should we consider dementia, or at least late life dementia, as a frailty syndrome? And so the burden of my argument is going to be that we should, and that means we get to start by saying what we mean about frailty and frailty syndromes and such. And that's how I'm going to proceed. I have some disclosures. So we've developed a number of things over the years for use with people who are frail, including the Clinical Frailty Scale and a Frailty Index and various other things. All of that is free for public use for education, research, and not-for-profit care. And for profit care, what we ask is that people not charge for it. So we make the copyright available, but we do ask users to agree not to charge, commercialize, or change it. I also founded a wee company called Ardea Outcomes. For the most part, this doesn't impinge on anything I will talk about, but there is one slide towards the end. We talk about the importance of individualized decision-making, which is what this company aims to promote. And as you've heard, I edit Brockler's textbook of geriatric medicine and gerontology. So 3 objectives then. First, I want to discuss what frailty is and how it's tied up with aging and therefore tied up with disease. Then I want to make the case to think about late life dementia as a multiply determined state. And in that, frailty plays a crucial role to make the risk factors riskier. And then if that's the case, I want us to consider what that means for how we do trials, how we provide care, and how we organize ourselves around the exciting and presumably increasingly useful topic of dementia prevention. So the number of people with dementia around the world is rising. That's because the population is aging, but interestingly, it's a bit complicated because the incidence, the age-specific incidence of dementia by several reviews is falling. And there's work here from Neurology in 2020, which shows that for the most part, most of the studies have shown that the incidence is going down. But at the same time, we also have data that the incidence of cognitive impairment is rising. And so how can that be? So one of my goals today is to propose why that might be so. So let's start with a case. So we've got a 75-year-old woman. She comes in with cognitive impairment. Actually, it's come on fairly suddenly by the account of her daughter who came in with her. And she's someone who developed delirium and has never been the same since. But a couple of interesting features here. The delirium was only 4 months ago when she got COVID. When she got COVID, it was the major sign that she had to compare with the general public health criteria. Prior to the onset of COVID, she had swum every day. And then since when COVID came on, she couldn't swim, the pools were closed. She still tried to get out for some golf, but she had been quite active. And why wouldn't she be? She's only 75. The type of dementia that it looked like she had, or the delirium that had not completely recovered, is one in which people are a bit more on the active side. So she was often losing things and then spending time looking for the things that she had lost, and then getting lost as she was trying to do that, or not being able to remember what it was she was trying to find. She asked the same question again and again and again. And she was uncharacteristically irritable. And I just highlight those because apart from the uncharacteristic irritability, which is common as these other two are, we don't actually test for this in the dementia clinical trials. It's kind of like a curiosity. Instead, we want to make sure that the person can spell the name of the Prime Minister backwards by 100 or whatever the test is. And we say, well, that's standardized. That's a good thing. And part of my argument is going to be, we're going to make headway in these areas. We've got to learn how to use patients and their care partners as our allies. So we did some testing. Our group likes the FreeCog test because there's no stealth copyright going to be asserted for that. On that, she was 17 out of 30. The memory index score was 9 out of 15. So she could remember most things with a cue. One of the nice things about the FreeCog is that it's got some really interesting questions about executive function, questions about judgment. And she actually did surprisingly well on that. The mini mental state exam, for those of you keeping score at home, was 21. The neurological exam done by some country geriatrician only really showed some mild paratonia and some slowing of gait. CT scan was read as showing some age-appropriate atrophy and a small degree of white matter change. So what's going on with her? Does her age matter? Or another way to ask this is she frail? So as a general proposition, as a rule of thumb, if age turns out to be important in a multivariable model, frailty will be important too, almost all the time. So what do we mean by frail? So there are a couple of ways to think about, or many ways to think about frailty, but two have tended to assert themselves. One is from the US, Linda Fried here at Columbia now, proposed the frailty phenotype or the frailty syndrome. And her group said, look, there are 5 things which are really characteristic of people as they become frail. And it's kind of a shrinkage type of a syndrome. So weight loss, fatigue, reduced high order functions, not the ADLs and ADLs, because that would be disability, and they were keen to not make that claim. Poor grip strength and slow walking speed. If someone had 3 of the 5, they're said to be frail. 2 of the 5, they're said to be pre-frail, and 0 of the 5, they're said to be robust. So I worked a lot with a mathematician, Arnold Meninsky, who died a year ago in May. And we had a number of conversations to try and think about what we meant by frailty. And in 2001, it became the case that we decided that what we had been doing, or most of what I've been doing up to that point, didn't make as much sense as this new way to think about it. And we self-consciously tried to think about what happens with aging. And more or less what happens with aging is things go wrong, and the things that go wrong accumulate. And so it was based on that idea. And this is obviously, everybody knows that, and it's been formulated in a bunch of ways. This is the pillars of aging approach that you're seeing, and it just says things happen at cellular, molecular, and protein levels, and then they toad up. And that's what the Frailty Index is meant to do. So the way we think about frailty is things go wrong with aging, and that's the upstream condition. Then frailty emerges at some point that can vary in the form that it takes when people have a lot of things wrong with them. So I'm a geriatrician in Canada. You have to be an internist first to do that. I've trained as an internist. I practiced in that way. I get the point about knowing exactly what's wrong with someone, but there's a point at which, if you want to stand back, the number of things that people have is important, particularly when they've got more than one thing wrong. So particularly when they're older. And there's multiple interacting medical and social problems. Here we're dealing more with the health things. We'll talk a little bit about social as we go. So what we see then is that when people become frail, then they become at risk of a number of frailty syndromes, particularly when they're stressed. So these are the things that in geriatrics for generations we've called the geriatric giants, things like falls and delirium and fluctuating disability and such. And my proposal is that we probably will get further ahead in pragmatic management and treatment of dementia if we think about it in that context, as opposed to arising from a single protein abnormality, or so I claim. So the Frailty Index Score, simplicity itself, take the number of things someone has wrong, divide it by the number of things you counted, because we all work from a health record or an epidemiological survey. Only certain things got measured in those surveys. Not everyone has measured the same thing each time. That's fine as a general proposition. You can trust people doing the survey to ask the questions important to them. And so we come up with this standard approach to a frailty index. The number of things that someone has wrong divided by the number of things that you counted. So the example here, because I work with mathematicians and physicists and such, and they say, if you're speaking with physicians, you better make it as clear as possible. So if you had 50 things that you counted and someone had 10 things wrong, 10 divided by 50 is 0.2. If they had nothing wrong, it'd be 0. If they had everything wrong they could possibly have, you might think, oh, that'd be 1. But it turns out it'd be somewhere closer to 0.67 for reasons that we can talk about in due course. But one of the magic things about the Frailty Index that has been discovered is that there's a limit to it for the most part when it's properly constructed. So how does that help? Well, it helps like this. So here are data which Arnold published in 2016. They come from Canada, and the data are based on 8 successive 2-year follow-up waves of the National Population Health Survey. And so on the x-axis is age, on the y-axis is the degree of frailty. There's the black line here, which shows the mean degree of frailty, and you can tell it goes up with age. And you know, the older people are, the more likely they are to have things wrong with them on average. You won't get a prize from New Zealand for that. This is where it starts to get cool. It's this, that the variability goes up too, and the variability particularly increases after about the age of 75 or so. So it's the variability that makes things interesting. 40-year-olds, when they're sick, they more or less all look about the same, but 80-year-olds don't, and 90-year-olds don't. And even though as a group, they have an increased risk of death, not everybody has the same increased risk. And as a first approximation, people with more things wrong have a greater risk of dying. And this is where it starts to get interesting. So don't take my word for it. Cardiologists have come around to this proposition as well. So here's the paper published in 2020 in the Journal of the American Heart Association. And again, on the x-axis is frailty index. On the y-axis is the hazard ratio for death. This is for all-cause mortality. You can see that it goes up as the frailty index goes up. But look here, this is what gave this paper some bite. is that the frailty index, more than a cardiovascular risk index, so you do the frailty index and you take out of it the items in that frailty index that are known to be traditional risk factors for heart or stroke, heart disease or stroke. And what's left over is a better predictor of cardiac mortality, of cardiovascular mortality, than the cardiovascular risk factors themselves in the Framingham Index. And so we were delighted to see this work come out. Particularly, they quoted our paper that said the same thing in 2014, that bounced around from one cardiac journal to the next and wound up in PLOS One. But this is true, and it's true for reasons that are non-trivial, and that's what we will be talking a bit more about. The fact that heart disease behaves in this way shouldn't be a surprise if we think about what's going on at the subcellular and cellular molecular level. So now I'm going to quote work from the Howlett lab at Dalhousie University, summarized in this review in Nature Aging in 2021. And by way of disclosure, Susan Howlett and I have been married for 38 years, and we have many work products. We're proud of this, but we're proud of the kids too. So for the longest time, people who looked at preclinical models and compared adult rodents to aged ones, they could pretty characteristically describe something like this. So if this is better function, this is worse. Susan works on cardiac excitation contraction coupling, but she's done it all. She's done everything from mouse echocardiography to excitation contraction coupling, the electrical bits, the physical contraction bits, the myocyte changes, and so on and so on. And pretty much you could bet that there would be something that would show up like this. Better function will be distributed in this way, and it would be higher. There'd be more of these rodents with better function when they were younger, when they're mere adults, than when they were aged. And so a lot of that work is there, and kind of interesting. But look, here's the same data presented by the degree of frailty. And so it turns out that some of this overlap that we see is made more evident, and how the age relationships work made clearer when we plot the same data by the degree of frailty of the particular rodent. And those insights that there's characteristic changes in clinical variables or molecular variables or at whatever scale with age also then gives us some insight in how to translate from the frailty index into real life, into things that clinicians can understand almost at a glance. So here's a bunch of data about falls, poor mobility, and balance. And the key thing about them, so these are, again, classic geriatric features. They integrate a lot of information about the health of an individual. And what we see here is that, again, on the x-axis for each of this is the degree of frailty calculated based on a thing called a comprehensive geriatric assessment. And these are just cumulative distribution scores. So you can see that unimpaired that the unimpaired people, say on a timed up and go test or the functional reach test, or even if you knew that they fell, or even if you just looked at them, they generally have lower degrees of frailty than the ones who are impaired, either by tests or by the history or by just a look. And this has allowed us then to think carefully about the ways in which these integrated variables, mobility, cognition, particularly attention, function, all start to come together. So we know that as humans, we've evolved to have upright bipedal ambulation. We know we've evolved to have opposable thumbs. We know we've evolved to have divided attention. We know we've evolved to have social engagement. So as these things start to fail, that's what frailty starts to look like as a first approximation for a group, which is to say that there are stereotypical clinical manifestations. So here is someone who is age 83 when this wee cartoon is done. And you can tell this person's out running. Now you can tell he's not running really quickly, but he's out running. He's 83. This is an 83-year-old, a woman, as it turns out, and she's lying in bed. And the way that you go from this to here occurs typically with characteristic steps. And that's what we tried to do when we constructed this thing called the Clinical Frailty Scale, is which we constructed as a means of allowing people who'd done a geriatric assessment to talk to each other about what it meant, what the stage, what the degree of frailty was, going from very fit all the way down to very to someone who lives with very severe frailty. There's also one for person who's terminally ill. And in the pandemic, this unexpectedly became employed as a rationing tool. And during the pandemic, in a very short period of time, I could kind of track where things were in the world, both by looking at the TV, but also by paying attention on our emails to who was writing to us to ask for permission to translate or for a meeting with the Minister of Health or something around the world. So the frailty scale was not intended as a rationing tool, but when we thought about it, better that than age. So this was an unexpected lesson. So I'm going to take you through a few quick cartoons of this. So in any clinical series, what we'll see is that people who are managing well, a clinical frailty scale score of 3, they're about as fit as you're going to see. So there are people who are fitter than that, just in a clinical series, they don't much show up. And so what does this mean? This means that you have someone whose medical problems are well controlled, even if they're occasionally symptomatic. But the key thing that's distinguishing them is that they're not regularly active compared beyond routine walking compared with their fitter peers. And I make the point here that there's that baseline because over the years, I've done a lot of work in the emergency department looking at frail older adults who are acutely unwell. And acute illness has a tendency to homogenize what all old people look like in the emergency department. If they're sick, particularly in there for some hours, they're on a stretcher, they're not well, they're lying there, they got the hair, they got the look, and you need some way to figure out not what are they like right now, it's what were they like 2 weeks ago. Because as a general proposition, we come to hospital with the expectation that somehow they're going to make us better. But if we don't know what better means, then it's going to be hard for anyone to convey these as goals. And as a general proposition, it turns out that it's harder to make someone better than they were 2 weeks before they got sick, particularly if they're older. So this then allows us to start to think about the care plan from the start as to what it is we're trying to achieve through hospitalization, hence the at baseline. So the next level up is to live with very mild frailty. And this marks the early transition from complete independence. So these people don't depend on others for help in their ADLs or their IADLs, but their symptoms often limit activities. And there's things that aren't formal ADLs and IADLs that they're still starting to need help with. And a common complaint is that they feel that they're slowed up or they're tired during the day. So you can see that 3 of these things would conform to elements of the frailty phenotype. So they've got some activity limitation, they're slowed up. Now you want to measure that objectively, and they've got a sense of fatigue. Skip through now to living with moderate frailty. So in mild frailty, people become more dependent in their instrumental activities of daily living, or the so-called IADLs. With moderate frailty, now they're at the point where they need help with all their outside activities and with keeping house. Inside, they often have problems with stairs, and they will often aim to live on one floor. Now, I know in New York, people do that anyway, but in Newfoundland, we go upstairs to go to bed. But I know people can do that in an apartment too, but still, this becomes a sign that things are not going particularly well. And bathing, often the way that people cope with that is to not bathe or sponge bath or those sorts of things. And they might even need at this point some minimal assistance, so queuing or standby. So they've got to be prompted because they're not alert to what's going on. Or you don't want to see dad putting the shirt on over his head and stuff. Someone feels the need to be right there. And that is a rapid way to get sense about someone being moderately frail, other things being equal. And again, these are judgment-based tests, right? So you say, well, look, the reason he can't get his arm up is because he has a problem with his shoulder, and that's fine. Do you want to just base it as a rule? Be trying to get the whole of the syndrome that's there. And then there's this one, which is living with very severe frailty. And anyone who's looked after any number of frail older adults will know that in the natural stage of dying, not on the cancer plan, but on the frailty plan, what happens is people spend more time in bed, and in bed they spend more time asleep. And this becomes a way that you can start to engage that conversation in ways that sometimes are shocking to the family members, but it unfolds in a very predictable way, predictable for the group. Like the hair loss ads say, your results may vary, but predictable for the group. And this tool winds up being really, really, really useful and not that hard to execute, and tells us things that start to make us understand that there's something real going on with this, even though it's not a blood test or an MRI. So these are data from Australia and New Zealand on 250,000 or more critically ill patients admitted to the ICUs there. And the idea of persistent critical illness has been operationalized as more or less are in the ICU for 10 days or more. And you can see that this red line here is the severity of illness, and this blue line is the degree of frailty that an individual had. So for fit people, there's a pretty clear demarcation between the two to get somewhere around day 10. But that's also the case for people who have very mild frailty, and day 10 shows up here as well. Now, again, these distances are getting smaller. But as the degree of frailty gets more, you see that what's going on at day 10 is that now the thing that keeping someone in the hospital after is not the severity of their illness, it's not what brought them in, it's what they're like before they came in. And so this is one of the insights that we can start to have in terms of the management, even of very ill patients, if we can gather the data on what they were like before they were sick. And the other thing which turns out to be tremendously helpful from a planning standpoint about understanding the degree of frailty, again, we're back to this scale here now, age here, degree of frailty here, but now the financially astute amongst you, and I'm a mere Canadian geriatrician, so that would not be me, but the financially astute people, so 4.5%, that would mean that there's a doubling time of every 15 years, because that's how it works for savings accounts or whatever that is. And that's how it works here too. It's an exponential process. So it doubles every 15 years. And just like for saving, it's not the first of the doubling time that's important, it's the last one. And for most people, age 75 to 90 is their last doubling time, because the more things you have wrong with you, the more likely you are to die. Not counterintuitive. And for most people, even though there's a theoretical doubling time between 90 and 105, on a population basis, this is where most death happens. And it's also where a large number of illnesses occur, including dementia. So these are data from Canada, and this is from age 60 to 100. On the y-axis is cumulative risk. And I want to just draw your attention to this, age 75. Age 75 is the year at which the risk for dementia really starts to increase. And that's not by coincidence. It's not by coincidence. That's the point at which we start to see the doubling, the last doubling, take off in terms of deficit accumulation. And as we think about what this means, how we're going to intervene with all of this, the reason that we want to start from a perspective about exercise is because exercise turns out to be, when we talked about the pillars of aging at the outset, something that has the ability to impact on each of these things that go wrong systematically with aging. And I want to make the point, because in the dementia world, we've turned ourselves inside out about symptomatic treatment, disease modifying, and wish we had disease modifying treatment. What does it look like? This is what it looks like. We've got it. It's exercise. So we need to start to learn from what we see when we see this. And what we see typically is we're seeing a multimodal intervention. And again, my claim would be that's not by coincidence, because it's helping us get at the background of the circumstances under which dementia arises. So what I said so far, I said I was going to start off to discuss frailty, the relationship with aging, and particular views of what this means to be a frailty syndrome. So I'll claim that I've done that, but just to drive it home, if frailty is related to aging, and if aging is multiply determined, if dementia is a frailty syndrome, then we should expect that it will conform to the idea of something that will happen to people arising in some who are predisposed for reasons we don't quite understand, and who get it with more than one thing wrong. That will be the typical case of the patient. And then we have to start to think about all the ways in which other pieces of information are available to us and start to explore those as means by which we may be able to reduce the impact of dementia, either by preventing it in the first instance or by mitigating its impact. And that means that we have to think about things like delirium, impaired mobility, impaired function, and impaired social engagement as pathways into the conundrum of late life dementia prevention. So I'm going to focus a little bit about inflammation. Now, I'm sure it's possible to know less about inflammation in age than I do, but it'd be kind of hard. So I'm just going to draw attention to a few basic facts. So one of them is that a couple of papers that came out in Lancet Journals in 2021 drew to attention that people who had been hospitalized with infection had a higher risk of developing dementia. So here is a group, and this is based on data from the UK, and the hazard rate of developing dementia within 3 months to about a year of being admitted to hospital, adjusted for age and sex, but not the degree of frailty, was higher, and that risk stayed for up to 9 years, which is as long as they did that study for. And that work was also coming at about the same time from 2 different data sets. And they said, look at here, in fact, having infection is bad for your cognitive health. And they looked at it in various ways. So one versus more infections. So more infections is worse. Bacterial versus viral. Bacterial is worse. CNS versus non-CNS. CNS is worse. And as these things, if you pardon me, add up, the risk gets higher. That didn't say much about frailty. And this was, for the most part, before COVID was available to us to help us understand what was going on. But now we have data about COVID as well, which you recall our patient had. And so here are data about COVID-19 survival by frailty status and delirium. So you can see that if we just look at the clinical frailty scale, the people who were pretty fit to start with had a much higher degree of survival than those who weren't so fit, and certainly a lot more than those who were quite severely or very severely frail. And delirium, yeah, you know, not so much easy to see what's going on there till you start to look at delirium and frailty coming together. So here is the signal of delirium, survival by a good clinical frailty scale score, a low one with and without delirium, versus one in which delirium might or might not be present, but the degree of frailty was higher. It's that intersection. The people who develop delirium are going to do worse for reasons that are worth thinking about. So we also know that frailty is a risk for delirium in and of itself, and this may be part of the issue that we're seeing here. And here's some data. It's a summary of meta-analyses, and it shows that for the most part, people who are frail to start with are more likely to develop delirium. And now this great paper by Terry Goldberg, published in JAMA Neurology in 2020, studies from 1999 on up, and showing again that delirium is a risk for dementia. And now we consider this against the background about what's happening. What are the community-based studies about dementia telling us what to expect? And one of the things that they're telling us, and this is the work from the Rush studies with David Bennett. The neuropathological features account for about half of late life dementia. Now, there's a lot of mixed dementia going on. In fact, only 8% of patients in the Rush studies, the community-based autopsy studies there, had pure Alzheimer's. And then we did some work, which I'll show you next. So working with a brilliant PhD student, Van postdoc now at Cambridge, Lindsay Wallace, we looked at the data from Rush. And on the x-axis here is the amount of Alzheimer's pathology that someone has, the plaques and tangles looked at under the microscope after they're dead. And here is the probability that they express dementia in life. And we have 3 degrees of frailty, a low degree, a middling degree, and a high degree of frailty. Let's go to this part of the curve to start with. So if you've got a lot of dementia, sorry, a lot of Alzheimer changes, then the chance of getting dementia is very high. But that's not where most people live. Most people are here. And so with them, what's important is not the plaques and tangles on their own, it's the plaques and tangles in relation to the degree of frailty that they have. And also drawing to attention are the large number of people down here who have dementia without having read the book and having the plaques and tangles. So what we found was a higher frailty associated with a higher odds of dementia, especially in people with low Alzheimer pathology. So now the folks who have back the 2011 consensus that we had to distinguish between Alzheimer's disease and Alzheimer's dementia, they would say, well, yeah, you know, we always told you that the two are separate, but it's this part of the curve here where you've got people who should have Alzheimer's disease based on the pathology and don't, where an unseemly discussion can take place. So I'm going to return to this. I hasten to add, we've replicated this work in one of the UK databases, and we've also done it to extend it for the not just plaques and tangles, but for 8 neuropathological features. So now we're looking for what may be tying all of this in. And if we're going to talk about frailty and delirium, then the leading candidate with delirium certainly right now is inflammation. And inflammation is also a leading candidate for why frailty exists. And there's the general thought about what's going on in the periphery and what's going on in the brain in the setting of chronic inflammation. Not the good stuff comes in, beats down the bacteria, and gets rid of all of that. It's the inflammation that persists even after the inciting insult has gone. And so this is showing up in these domains and looks like it's worthy for consideration. I have a colleague who reminded me the other day that we're so old that when we trained, MS was inflammatory and Alzheimer's was neurodegenerative, but it's the opposite now, apparently. So, the relationship between neuropathology and who gets dementia is moderated by the degree of frailty. Matteo Cesari and colleagues in Milan and Rome have demonstrated the same thing in the ADNI database for biomarkers. So now I want to, and we've done work on genetic risk, and we've shown the same thing. It's independent of ApoE, but this was a really interesting opportunity, again, with a brilliant young fellow now at Queensland named David Ward. He did a postdoc with us. We used data from the UK Biobank. So here's the hazard rate for incident dementia. And blue is low polygenic risk, intermediate polygenic risk, and high polygenic risk. And the reference is low polygenic risk and low frailty. And you can see that the higher the degree of frailty, the higher the impact of high genetic risk, but in fact, any genetic risk, even the low. And in fact, proportionately, where the genetic risk is having its largest proportionate effect is in people with low frailty. Once you get up beyond that, genetic risk is driven as much by the degree of frailty as it is by the genes. And interestingly, when we look at the things that are known to be protective here, we find that this is mediated through the impact on the degree of frailty. So here are the 4 healthy lifestyle behaviors and that were looked at in UK Biobank, acknowledging that people over the age of 60, it's white Europeans only who are cognitively normal at baseline, but this is with 5 years of follow-up. And here's the Frailty Index scores from about 0.11 to 0.17, so reflecting that they're not that frail to start with. But still, you can see that as the number of behaviors increases, the Frailty Index goes down. And so the impact of the healthy lifestyle behaviors in this sample is mediated by the degree of frailty that people have. So that leads us to this conclusion, that frailty is not a disease, but it profoundly influences disease expression. So the lowest risk is to have a healthy brain, as represented by this cartoon of a neuron here, and to be fit. And the worst thing, the highest dementia risk, is to have brains with plaques and tangles and Lewy bodies and such, and to be frail. But the interesting thing is that this risk is not as low as here, but there's a lower risk associated with dementia in very fit people, even the presence of brain pathology. So I hasten to add that I've emphasized here, for the most part, physical frailty, or the things that people have wrong with them from a medical standpoint. Social vulnerability is also very important, and the two are tied up. And here's data on some work from a series of patients. This is 882 consults that I saw in the emergency department for medicine, but we managed to get a geriatric assessment done on them all. And the way we do the geriatric assessment, it includes items that go into social vulnerability index. And so Jasmine Ma, again, brilliant young woman, studying to be a geriatrician, working on her PhD on social vulnerability, got at these data and said, let's do the simplest possible thing. Let's just look at the regression coefficients around the decision of who comes into the hospital and what happens to them. Gray is frailty and orange is social vulnerability. So where I work at the Halifax Infirmary in Nova Scotia, whether you come in or not, and these are all adjusted for severity of acute illness, whether you come in is driven more by the degree of frailty than it is by social vulnerability. If you stay a long time, that's more having to do with social vulnerability than the degree of frailty. If you are there long enough to be identified as requiring nursing home care, but there's no bed for you, so-called ALC, alternate length of care, that's a combination of the two with a bit of predominance by social vulnerability. Death in hospital is still mostly about the degree of frailty, and whether you get home, both wind up being important as well. So I haven't emphasized social vulnerability, but it's extremely important and plays out in clinically detectable ways. So what does this mean then for how we provide healthcare to older adults? I think it means a lot, because at the moment, routine hospital care, at least where I work, is unnecessarily risky. Routine hospital care does not well serve the needs of people coming with many things wrong all at once. For the most part, we're still, in our mind, training people with our words about the normal thing is to have one thing wrong, because then we've got this fancy gadget stuff that we can do if you got that one thing. And unfortunately, often what students and house staff hear is that that's how it should be. These other people, they shouldn't be here. And sometimes one can be forgiven saying, well, not if you're going to look after them. But we have to have better ways to take into account the many vulnerabilities of the patients that we have. And I think if we start to think about it like this, we also have an opportunity to prevent dementia. So these are some data from 2017 and a really cool set of before-after studies done by some American surgeons. I just want to draw your attention to this. It was just before-after work on the impact that screening for frailty, nothing but management, just screening for frailty had. And the 30-day mortality before screening was 12.2%, after 3.8%. The one-year mortality before screening, 34.5%, after 11.7%. All this is telling us is that there are big opportunities here, because imagine if we did things more than just the screening bit. So this is old age ain't no place for nihilists. So, and it may well be that we could bring about interventions based on attenuating in some fashion chronic inflammation. And a lot of what we're seeing from the geroscience agenda unfolding is work that would make this plausible. And then when we were looking at this in Canada for our update consensus conference on diagnosis and treatment of dementia and its prevention, we started to enumerate all the things that were in the Lancet Commission discussion about across the life course, all the opportunities we had to intervene. And that in the Lancet Dementia Commission estimated about 40% of dementia risks were modifiable. Some of them very early, like education, some of them through midlife, but a large number of things later in life. And so it gives rise to the idea that maybe multifactorial, multimodal interventions targeted at dementia would be helpful, which of course is the rationale behind the Finnish geriatric study, the FINGER study, published by Kivi-Pelto in Lancet Neurology in 2017, and the worldwide FINGER studies that are going on now. And there is a lot of emphasis, and appropriately so, being looked at exercise and people looking at various types of exercise. And I think that's helpful. That's part of the discussion. But I think a really important part of the discussion as well is, how does any amount of exercise compare with getting off the couch? So if it's a sedentary lifestyle, all these things are important. We're going to need to know ultimately, which combination of this is best. But how about if we just got people up to walk? And how about if we got people up to walk, and we know that the purpose of the worldwide FINGER studies is because FINGER itself was very intense and costly, and the whole worldwide effort to see, can we scale it? And so in Canada, we've our contribution to the FINGER is something called Can Thumbs Up, and it's internet-based, and that's very groovy for the folks who've got it. But in Nova Scotia, where I work, and particularly in Cape Breton, where I do a lot of outreach work, it's rural internet, which is to say, not much. But one of the things that Cape Breton has is a really strong culture based on a bunch of good stuff, social engagement and music, also based on, deep fried Mars bars and getting into a fight and drinking too much and those sorts of things. So can we find out a way to bring people together who are at risk and emphasize the good parts of it independently of the internet, but still use some of the fancy technology that's available for this type of work? So I think as we go forward, the way that I'd like to see us think about this, and what I would claim that these insights in how dementia works means for clinical trials and dementia treatment and prevention, is we should start thinking about biomarkers, including neuropathology, presumably the ultimate biomarker, as risk factors, not as disease defining, and things that, though they're not modifiable, them being expressed as dementia might well be. I think we need to stop turning away people from our trials who are the ones who are likely to develop dementia, which is what happens when we insist on, they'll get to have one thing wrong, and you better be like an Olympic athlete just with, can't spell the name of the prime minister backwards. And now we come into the trial, and then we wonder why the rates of conversion to dementia were lower, because these are the people who converted the same rates. We need to incorporate people into trials who are likely to get dementia. We have to better understand what the targets are, both the mechanistic and the symptomatic ones, but be prepared to listen to what patients and families are telling us, not just about the problems they have at the start, but how are these problems responding to treatment? And I think that if we had done that with the cholinesterase inhibitors, we would have quickly thought more rigorously about executive function as a target for treatment, as opposed to memory, but I digress. And as a general proposition, though, I think that things that allow us to come up with better executive function will trump, and I pardon the use of the word, a similar effect size in the memory test scores. So to sum up then, I said I was going to talk about in what frailty consists. It's a multiply determined state, and it reflects disorder or accelerated aging. Our particular take on it is there's many ways to be frail, and that includes falls, impaired mobility, functional decline, delirium. And I think dementia could reasonably be added to this list for the good consequences that it would bring in terms of how we're thinking about dementia in late life. And that the degree of frailty is crucial in understanding where the risk for dementia lies. So the second thing I want to talk about was, how does this crucial role come about? And we showed you data with respect to neuropathology. I hinted at the biomarker stuff. I showed some of the polygenic risk stuff. We've got some work going on right now looking at neuropsychological tests. I'm hoping soon for some neuroimaging work on the same sort of the thing. And what, for me, I would want to underscore is that the impact of lifestyle factors appears to be mediated by their impact on frailty. And I think that helps us build the case for this being more than a trivial association. And again, frailty, we should be considering we should be considering targeting frailty to prevent dementia, we should then take on board that it's multimodal interventions is what we mean when we're doing trials. I think we also have to offer a multimodal intervention. See, this other thing we're going to do, will it improve over what we can offer anyone anyway? So it's the current exclusion criteria that need to adapt if the results are going to A, be show any effect, and B, are going to be able to generalize. And the other thing is, we should not imagine that prevented dementia is normal cognitive function. I can't conceive of how that would be so. And this may get us at the conundrum of how it is that the age-specific incidence of dementia is falling, but the degree of cognitive impairment is rising, because the cognitive impairment may be what likely is what, in my view, prevented dementia would look like. So back to our woman here. So does her age matter? Yes. And it matters for all the reasons we talked about. It matters because frailty matters. I turned 66 a couple weeks ago, so I can now talk about in my career what I've done when I was a boy. But what I can also do is acknowledge people have supported me my entire career. That includes Canadian Institutes for Health Research, Canadian Frailty Network, more recently Canadian Space Agency, Alzheimer's Society of Canada. Just want to underscore here the Fountain Family Innovation Fund and the Q Health Sciences Foundation, which has allowed me to resist the fashion of peer review. Research Nova Scotia, a really fantastic new program. The Mathematics, Information Technology, and Computer Science program from the National Research Council of Canada, the Housing Medical Research Foundation, which is how I get my chair supported. And then, as we've heard, the Ryman Healthcare Foundation. Friends and colleagues, one of the great things about a career in academic medicine is I've seen people come on as students and then be trainees and then become colleagues, and some who stuck around become cherished colleagues and friends. And that is one of the things that mitigates whatever bad senses one have about being older. I want to underscore Susan Hallett, about whom you've heard, Andrew Rutenberg, who's professor of physics at Dal, and whom Earl met some years ago when he knew he was unwell, and kind of established that Andrew would be there to take up the cudgels on understanding frailty formally as a complex state. I thank all of them for everything they've done, and I thank you for listening. And just one other thing, I don't want to pass up this opportunity with such a big, important, influential audience. We're always open for postdoc inquiries of someone who is really good at whose quantitative skills are quite good. So we don't mean, got an A in stats. We mean computer science degrees or physics or those sorts of things, and superior communication abilities. God knows it's hard enough just to understand what the math is. And in 2024, we anticipate having a Tier 2 Canada Research Chair in quantitative aspects of aging for people who are planning a little bit ahead. Thank you very much. I'll stop there.
Seems like the one action item for us is to name and scale frailty, use it as a guide that informs our treatment and intervention, and follow it to see how it responds. So that's our take home.
I wouldn't argue with that.
You wouldn't argue with that. Thanks again.
Thank you.